And so I am going to try to explain why I consider that we should treat high-risk smoldering myeloma patients. This is the natural history of the disease, and we usually start treatment with myeloma becomes as an active disease. And what does active myeloma mean? Bone pain, usually in the back and ribs, broken bones, usually in the spine, fever, infections, anemia, lytic lesions, renal impairment. So what I am proposing is to move the initiation of treatment just before the disease is over with the clinical manifestations. And does this make sense, or is this something completely ridiculous? And if we go back to the oncologic perspective, I think that the early intervention in almost all malignancies is the main target for them, with the two possible objectives: to try to control the disease or even to cure. And if we can see here the outcome from a polypus to colon cancer and even liver metastasis, my question would be, would you consider appropriate to wait until the colon cancer resulted in liver involvement to plan active treatment? The answer is no, but this is what Dr. Leleu will propose for patients with smoldering. He will propose to wait until myeloma-related symptomatology is developed. And this is the myeloma-related symptomatology. And although I don't agree with him, so I tried to put in his mind in order to try to understand his thoughts. And is there any rationale? And maybe if we come back many years ago, some trials were conducted in smoldering myeloma patients with conventional agents, with thalidomide, and even with bisphosphonates. And it's completely true that these trials did not show any benefit in terms of time to progression and in terms of overall survival. But the main problem for these trials is that low, intermediate, and high-risk smoldering myeloma patients were included. So this can be potentially the reason for not having any significant benefit. Now, we know that smoldering is a heterogeneous disease, and we can potentially identify different subgroups of smoldering myeloma patients: low risk, intermediate risk, and high risk. So I would like to focus only on high-risk smoldering myeloma patients. And the appropriate question, probably if you have in front of you a smoldering myeloma patients, is it possible to identify the risk of progression to myeloma for each smoldering myeloma patients? And the answer is yes, and I am not going to focus on all different risk models already published to identify the risk of progression to myeloma. But basically, the Mayo Clinic model using the M component and plasma cell bone marrow infiltration, or the Spanish model using flow cytometry, cytogenetic abnormalities, gene expression profiling, PET-CT, all of them are able to identify a subgroup of smoldering myeloma patients in which the risk of progression to myeloma is approximately 50% at 2 years. In other words, median time to progression to active disease, approximately 2 years. And it's completely true, and yesterday we were discussing about this after the Vincent's talk about how to proceed in the clinical practice with the patients with smoldering, because it's completely true that we have a list of different risk models, and so how to proceed with our patients. And you know that there is a proposal conducted by International Myeloma Foundation together with the International Myeloma Working Group in order to try to collect baseline characteristics of 1,000 smoldering myeloma patients in order to define a simple score to well define the risk of progression to myeloma. And in the meantime, my proposal would be to use the Mayo Clinic model, available in all centers, M component, plasma cell bone marrow infiltration, Spanish model, if flow cytometry is available, together with immunoparesis, or why not the evolving pattern, also described by Mayo Clinic and also confirmed by the group of Barcelona. And is it possible to do this? And I know that probably Xavier will present you about the agreement or the concordance among the different risk models. And the group of Ola Landreg published some years ago this trial or this work in which they reported a significant disagreement between the Spanish and the Mayo risk model in a series of 77 smoldering myeloma patients, especially because some smoldering myeloma patients at low risk, according to the Mayo risk model, were considered as high risk according to the PETEMA model. This can be true, but so my next question would be, do you know what was the real outcome for these patients in which there was a disagreement? Were actually they at a low risk, intermediate, or high risk? Nobody knows because in the publication is not present and this trial has not been updated. But what I can show you is that in our Curative trial, so high-risk smoldering myeloma patients were included according to the Mayo and or Spanish model. And when we evaluated the hazard ratio for progression of smoldering myeloma patients according to the Mayo model and or according to the Spanish model, you can see that there was a good concordance, and in fact the hazard ratio for progression was 0.2 for both models. Is there any additional reason to plan early treatment for high-risk smoldering myeloma patients? Any biological reason? Irene showed yesterday this slide, and from the biological point of view and from the genetic point of view, you can see here smoldering. And smoldering is genetically a disease different to myeloma. And probably high-risk smoldering myeloma patients are very similar to myeloma. And this is the reason why we have to focus on high risk and probably from the biological point of view, even a bit earlier. But so we are going to treat a disease also biologically different. So with all these points, so Spanish myeloma group decided to plan smoldering inside heterogeneous disease. It is possible to identify the high-risk subgroup of smoldering myeloma patients. The oncology perspective supports the early treatment. The biology of the disease is different, so why not to plan early treatment for high-risk smoldering myeloma? But of course, we had to support this. And for this, we decided to conduct the Curative trial. And this trial was conducted many years ago. And in fact, the median follow-up for this study is now more than 6 years. But we decided to select 125 high-risk smoldering myeloma patients and to randomize them to receive early treatment with lenalidomide and dexamethasone versus observation. The primary endpoint was time to progression to myeloma. And you can see that after a longer follow-up, more than 6 years, there was a significant benefit in terms of both progression-free survival, but also in terms of overall survival. And in addition, the early treatment, in this case with lenalidomide and dexamethasone, was very well tolerated. So I think that this study was the starting point to plan early treatment in high-risk smoldering myeloma. And in fact, you have also to know that this study was one of the key points to support the new criteria for the definition of myeloma. Because according to this study, and if you see the new criteria for the definition of myeloma, I can say that everybody here in the room is treating smoldering myeloma patients. Smoldering myeloma patients in the past that now they are considered as myeloma. Smoldering myeloma patients with any one or more of the biomarkers, serum-free light chain ratio higher than 100, plasma cell bone marrow infiltration higher than 60%, more than 2 focal lesions on MRI, and one important concept, new imaging assessments. With the use of PET-CT, low-dose CT, you are doing the diagnosis of myeloma to more patients than in the past were considered smoldering. So everybody is treating smoldering myeloma patients, but they are called now myeloma. And according to all this background, in the past this was the proposed algorithm. So multiple myeloma, those high-risk smoldering myeloma, ultra-high-risk smoldering myeloma, and for the high risk, so the algorithm proposed to include these patients in clinical trials. And this is what we have been doing over these years. And in fact, if you go to clinicaltrials.gov, there are more than 50 clinical trials currently ongoing focusing on early treatment on high-risk smoldering myeloma patients with 2 different objectives: to try to delay the progression to myeloma, and in line with this, you can have clinical trials with ilotuzumab plus lenalidomide and dexamethasone, or daratumumab single agent, ixazomib, lenalidomide and dexamethasone, pembrolizumab, isatuximab, etc. But also there is another proposal is to try to cure the disease with 2 more aggressive treatments. If we focus on to try to delay the disease progression, just to mention this small study conducted with carfilzomib, lenalidomide and dexamethasone, in which you can see that the complete response rate was 100%. And minimal residual disease negative was reached by a significant proportion of patients. But what is important is that when they compared this response rate with newly diagnosed myeloma patients, KRD worked better in high-risk smoldering myeloma. And this combination was the rationale for the CESAR study, conducted by the Spanish myeloma group in 90 high-risk smoldering myeloma patients, in which we plan the cure, at least for some high-risk smoldering myeloma patients. And these 90 patients are receiving induction with carfilzomib, lenalidomide and dexamethasone, transplant, consolidation with KRD, and maintenance with lenalidomide and dexamethasone for up to 2 years. Preliminary results were presented at the last ASCENT meeting, and you can see so the overall response rate is 100%, but I would like to focus on the complete response rate, and you can see after induction, 43% of patients are in complete response, 57% after transplant, more than 70% after consolidation, and 90% of patients receiving maintenance are in complete response. But the primary objective is minimal residual disease negative, and you can see the minimal residual disease negative rate increases over the time. The median follow-up is very short, but the outcome is very good. Of course, we have to wait longer follow-up. And the other proposal is being done in the United States, and the PIs are Saji Kumar together with Brian Dury. Similar approach, KRD, followed or not by transplant, consolidation and maintenance, but they decided to add daratumumab as monoclonal antibody. So in order to finish my presentation, I would say that in the future, probably high-risk smoldering myeloma patients should receive early treatment. But my position is that probably we will treat to high-risk smoldering myeloma patients, especially because new biomarkers will be validated and more smoldering myeloma patients will be considered as myeloma, and patients will be treated as patients with active disease, and they will get much more benefit. And finally, just to thanks to all investigators participating in the Spanish myeloma group, because thanks to their collaboration, we are able to conduct these trials and in order to support the early treatment for high-risk smoldering myeloma. Thank you very much.